Joining us online, those of you who don't know me, I'm Rick Page. I'm the Dean of the Larner College of Medicine. I'm so pleased to welcome you today to this very special event. This is the 9th annual Vito Imbasciani, PhD, MD, class of '85, and George DiSalvo LGBTQ Health Equity Lecture. And today this is entitled Addressing the Health Needs of Sexual and Gender Minority Populations in the United States. You're going to be hearing about your speaker in just a moment. Let me start off by expressing my gratitude to Dr. Vito Imbasciani and his husband, George DiSalvo. It's through their generosity that we're here today, expanding our knowledge and understanding of the issues of LGBTQ healthcare. I had the great pleasure of spending a significant amount of time a few weeks ago with Vito and George. Earlier this month, when they were here on campus in person, they send their regards. Unfortunately, they're not able to join us today. I told them how much we appreciate the support they've given us and the many important voices we've been able to bring to this campus, thanks to their enduring generosity. I know how much this means to them, and they've certainly heard from me how much I appreciate what they've done for our college. This was the first and may still be the only endowed lecture dedicated to LGBTQ health in any medical school in the United States. And we're proud to further the goals of healthcare by shining a light on the specific needs of these populations. This lecture is consistent with our college statement on professionalism, including commitment to treating everyone with cultural humility, kindness, and respect. We recognize that we must commit and are better through promoting equity and support in our community to make us a diverse and inclusive community. I'm especially pleased today that we get to hear from one of our own, an alum of the Larner College of Medicine, then the UVM College of Medicine, Dr. Philip A. Chan, a member of the class of 2006. He's gone on to important work that you'll hear about more in just a moment. Again, welcome, Dr. Chan. There he is, with whom I got to visit earlier today and even found out he knows my nephew, who's a doctor at Brown and took his degree there and works as a hospitalist. Here to introduce Dr. Chan is Dr. Ann Doherty. Dr. Doherty is an associate professor of obstetrics, gynecology, and reproductive sciences and member of the college class of 2009. She's also director for gender equity in our Office of Diversity, Equity, and Inclusion. In that position, Dr. Doherty has brought exceptional energy and insights to bear on the issues of gender equity here at Larner and throughout our community. It's also my pleasure now to welcome Dr. Doherty to introduce our speaker. Dr. Doherty.
Thank you so much, Dean Page. I'm so happy to be here. And I want to welcome everyone to this year's Larner College of Medicine, Vito Imbasciani, George DiSalvo, LGBTQ Health Equity Lecture. You've heard, my name is Ann Doherty. I am an alum of the Larner College of Medicine and excited to be a part of fostering equity and inclusion at our institution. On behalf of Dr. Margaret Tando, our Associate Dean for Diversity, Equity, and Inclusion, who is traveling out of the country at this time and unable to join us, I'd like to welcome all of you, both here in person as well as those viewing remotely. And thank you for joining us for this event. Philip Chan, MD, 2006, MS, 2004, is an associate professor in the Department of Medicine at the Alpert Medical School and the Department of Behavioral and Social Sciences at the School of Public Health at Brown University. He is the Chief Medical Officer at the Open Door Health Clinic and Medical Director at the Rhode Island Department of Health for the Center for HIV, Hepatitis, STD, and TB Epidemiology. His passions include improving access to healthcare and providing preventative medicine for marginalized populations. Dr. Chan completed his undergraduate, graduate, and medical school education at the University of Vermont. He subsequently completed an internal medicine residency and clinical research fellowships at Brown University. Informed by his experiences, Dr. Chan started the state-supported STD clinic in 2012 in the urban center of Providence, Rhode Island, which currently provides safety net care to underserved populations. He's since expanded on these efforts to lead multiple NIH, CDC, SAMHSA, and other grants related to HIV, STD care and prevention. Dr. Chan also started the first pre-exposure prophylaxis program for HIV prevention in the state and leads multiple initiatives, including ongoing social media and online efforts to engage at-risk populations online, such as gay, bisexual, and men who have sex with men, addressing health disparities, including issues related to cost and financial sustainability, as well as understanding behaviors and developing efficacious interventions to improve the uptake of HIV, STD preventative services. In early 2020, Dr. Chan started a primary care clinic for the LGBTQ+ community to improve access to primary and gender care in Providence. At the center of these approaches is a focus on underserved populations and improving access to preventative services. In addition to his numerous leadership roles and respected research, Dr. Chan serves on numerous national boards and committees and serves as a reviewer on several publications, including the editorial board of sexually transmitted diseases. He's also the medical director at the Rhode Island Department of Health for their Center for HIV, Hepatitis, STD, and TB Epidemiology. During the pandemic, Dr. Chan led aspects of this COVID-19 response for the state of Rhode Island as well. Please help me in warmly welcoming Dr. Philip Chan to present the Vito Imbasciani George DiSalvo LGBTQ Health Equity Lecture.
Thank you. So good morning. Thank you for that very kind introduction. It is much appreciated. You know, I was talking to Dean Page before this, and you know, I could never imagine that I would be here today talking about the things that I'm going to talk about, not from a topical perspective, but just from the twists and turns that leads one in one's career. I guess one piece of advice to start is just take advantage of the opportunities, have a little bit of flexibility in your career, and you will do great things. It's just, no one can often predict where they'll end up, the dean included, and I'm sure as I look across my colleagues, all of us have meandered to some degree to where we are today. But I'm really thrilled to be here today to talk about some of the work that I pursued for the last decade. One thing I will not talk about today is my COVID work, which has been, I think, for a lot of us in public health and medicine. The pandemic has brought us into new territory and some different work approaches. Happy to answer any questions about that. But I was also reflecting, you know, 15 years ago, I sat in this very room as a graduate, taking step one, taking other tests as well. And my brother as well, we both grew up in the state of New Hampshire. My brother serves as a state epidemiologist for the New Hampshire Department of Health. And I myself moved down to Rhode Island, went to Brown residency, went to Brown fellowship as well, and stayed on there as faculty. My dad was actually the first doctor in our family. He immigrated from Hong Kong. He's a cardiologist who graduated as well from UVM in 1976, I believe, if I remember right. I was born in 78. Time flies. I did take a brief during residency and a little bit thereafter. I thought actually I was going to pursue a career in global health. Has anyone in here practiced medicine or done a clinic somewhere outside of the United States? A couple. I would strongly encourage it at some point in your career. I think it gives very unique perspective, both to medicine as well as American way of life here. I'm sure many of you have traveled throughout parts of the world, but doing medicine, doing clinical care in other parts of the world really makes you appreciate what we have here in our country And I'm just grateful. And if any of you have traveled to underserved countries, resource limited settings, paved roads, some of the very basic things that we take for granted in the US are really a luxury. But definitely make it a point at some point to do some international medicine, early on in your careers. So I'm going to talk a little bit about some of our work related to sex and gender. I'm going to start with just some basic definitions. I'm hoping that most people in here have had at least some basic terminology, some basic teaching education on these terms. But let's talk for a second about sex and gender, related but different, right? So sex tends to refer to biological differences. We're talking about anatomy, chromosomes, genes, etc. Whereas gender refers to social and cultural identity. It's how one expresses themselves and their gender. They're related, but they're different. And often I hear them confused all the time. In terms of gender identity, right? Someone can be male, female, neither, both, somewhere in the between, or other. Really exists as a spectrum. When we talk about someone being the same gender as they were born in, right? Cisgender. So someone who's the same gender now as they were born in terms of biological sex, that would be a cisgender individual. Transgender means that you differ. So someone who was born, for example, a transgender woman would have been born male at birth and now identify as female. Likewise, transgender man, someone that was born female and identifies as a male. And we'll talk about this a little bit more. And this exists on a spectrum. And that's one thing I've learned to appreciate over the decade of my career, is that gender especially exists as a spectrum. And there can be non-binary, genderqueer, other. This is different from sexual orientation, right? So when we talk about sexual orientation refers to the sex of those whom one is sexually attracted to. And typically they're described, right? Straight, gay, lesbian, bisexual, queer, other. And that's different than gender identity. And I feel like a lot of times we kind of lump them all in. And I will say as a disclaimer, a lot of my work, a lot of what I'm going to talk about today is related more to cisgender, especially gay and bisexual men. That's as a infectious diseases adult physician. That's where a lot of my work has been. And I'll talk a little bit more about that in a second. I do want to encourage all of us as we progress in our careers, and also for those administrators that may be listening or here, we have to also capture this data. So I want to also offer the disclaimer that I work in public health. It's difficult and none of us like to be categorized, right? But we have to be able to capture this information so that we can report on outcomes and disparities. And I've also learned this over the last 10 years of my life, is that if you ignore populations, right, then you don't know what's going on. And so as an example, in the field of HIV, for a long time, we didn't collect gender data, right? So we had no idea whether gender diverse populations were being disproportionately impacted by HIV. Why? Because we didn't collect the data. And it's similar across other medical specialties as well. If we don't collect data on some of these groups, then we can't tell what's happening or how badly there may be disproportionate care. So I know sometimes it's difficult to categorize people, but I do encourage us, and these questions are from the CDC. This is what we do in public health in terms of capturing data, looking at sexual orientation and gender identity. In terms of gender identity, we tend to ask a two-pronged question, thinking of, do you think of yourself as male, female, transgender man, trans woman, transgender woman, trans woman, or other? And then the second part of that question is, what was the sex that was originally listed on your birth certificate? And sometimes I think people, for some of our general population, they may not get or understand why we're asking those questions. And I would use that as a moment to educate the general public and for people that are questioning about that. We also, in terms of respecting patients, also ask about what name do you prefer to be called? Understanding that the name that's listed on someone's original birth certificate is sometimes much different than the name that they prefer to be called. And finally, also really important from a respect perspective and understanding patients is, what are your pronouns? And this is something over the last decade of my career that has really been reinforced time and time again, is that we want to use the correct pronouns of our patients in order to show respect and in order to provide them the best care as possible. And so I think it's important from a systems perspective that we also ask that out front from the very first encounter throughout the entire medical visit. And sometimes for some of us, like myself, that was brought up more in a cisgender culture and atmosphere, sometimes it can be a little bit different, right? Using they, them pronouns. It took me a little bit of time when I first started this work to get used to using those pronouns. And now, you know what? It's part of my language. It's part of my culture as well. So I do encourage us to think about this from the systems level. And we'll talk a little bit about this in a second. But when we hire, when we make hires for our clinic, we take it as importantly, as seriously, that front desk person all the way up to the physician. Because it's that front desk person that really has that first interaction, that first engagement with patients. And you want that to be a positive experience, and you want to train them as well. So we take a lot of care and thought when we hire people, not just the MDs, which I think a lot of attention is focused on. I am an MD, but also the front desk and the secretarial staff and the administrative staff. It's really a bottom top throughout an organization approach that you really have to think about these things. And I think to further confuse matters, when you look at, here in public health, when we talk about sexual behaviors, and specifically when we talk about disease transmission, right, and HIV, one other term that we commonly use is men who have sex with men. And that refers to clinical behaviors. It refers to a man, whether it be usually biological born man, who's having sex with other men. And the reason why in public health that we tend to talk a little bit more about sexual behaviors, clinical behaviors, is because that is the way, that is the more of a risk for HIV transmission. And so a lot of times in public health and literature, you'll see this term MSM, which actually is not really referring to gender identity or sexual orientation, right? You can have a heterosexual man who's also having sex with other men, right? So that's why it's important to be accurate and correct with these terminologies. And it does get a little bit confusing at times. If you don't leave here with anything else, I do want to encourage you all to learn to take a good sexual history. Has anyone here ever taken a sexual history? How many people in here have taken a sexual history? Yeah. How many people in here are a little bit uncomfortable with taking a sexual history? Yeah, right? It's a little bit uncomfortable. One thing though that I've learned over time is that it's only, you're going to make the patient uncomfortable if you're uncomfortable. So you just have to gain some comfort, and there is a little bit of a standardized way to do this, and there's not an exact correct way to do this. Everyone finds their own rhythm. You find your own words and verbiage that you want to ask, but in general, this is something that's put forth from the CDC. It's called the 5 Ps, something just to use as a framework on how to take a sexual history. But I do encourage you all to consider weaving this into your assessments and your evaluations. And the reason for this, regardless of what field you go into, I'm reminded that every year, at least in the state of Rhode Island, because I review all these cases, is that we have a handful of people, a little bit older at times, 60s, maybe 70s, who present with fever and weight loss, chills, night sweats. And your first thought on the differential is what? Cancer. But it turns out, and these people go through the $1 million workup, right? You get your colonoscopy, you get your endoscopy, you get the pan scan, of course, head to toe. And it turns out that they have what? HIV. So, and remembering too that an HIV test costs about $1.50 to run. So just reminded that, and when you look at these cases, a lot of times the sexual history was never taken, it was missed. So I just want to encourage you all to have a lower threshold for taking a sexual history and for considering things like HIV, especially when you see it in the right epi context. And I'm an adult infectious disease doctor, right? What is it about infectious disease doctor? It's all about the social history, right? You want to get that travel history, you want to get the sexual history. But I've seen this time and time again, and even for things like syphilis, like no one bothered to examine the genitals, right? And they had these big chancres that were all over the genitals. So just again, make sure to do a careful physical exam and take that careful history. And when we talk about LGBTQ specific healthcare disparities, they are uniform throughout the field of medicine. And I'm going to focus a lot today on HIVs, HIV, STIs, sexual health. But no matter what you look at, whether it be mental health, substance use, chronic diseases, I just did a report actually on cardiovascular health, significant disparities exist. And the reason for these disparities are numerous. They also include reasons like the lack of culturally sensitive care. We see a lot of LGBTQ individuals who are afraid to engage the medical system. I have a lot of patients that, for example, have primary care doctors, but don't feel comfortable talking to their primary care doctors about sexual health. And that's just not right. It should be that sexual health is part of primary care. And we want our patients to be honest and upfront with us. That's why a lot of us have become and are becoming physicians. So let's talk about HIV, STI, sexual health just briefly. So one thing that I'm struck, so the good news in general is that HIV is coming down in the United States. So we've made good progress. We are working to get to 0 new diagnoses, which is all great. I think what has always been striking in the bottom left-hand corner here, you will see that the top groups affected are gay, bisexual men, other men who have sex with men, and specifically communities of color. So Black, African-American, Hispanic, Latinx. And there were some data that came out from the CDC a couple of years ago that calculated that Black gay men in the United States of America have a 1 in 2 lifetime risk of HIV. Now let that sink in for a second. Here in the greatest country in the world, Black gay men have a 1 in 2 lifetime risk of HIV. So you don't need to go to Africa, you don't need to go to other countries around the world to really see the disparities here in the United States. And you know what? We need to do better. We can do better. We should be doing better. And that to me has always been, I'm just reminded with that statistic of how much better we should be doing. And so again, I know that many of you are not going to go into the sexual health field, but I just want you to all keep in mind that there are uniform recommendations and the data is clear that everyone really should be screened at least once in their lifetime for HIV and more frequently if you are sexually active. And again, just going back to that story, if you go into oncology or cardiology or pulmonary, critical care, family practice for sure, that you just want to incorporate HIV screening and other STIs into your practice. And that is how we are going to end the HIV epidemic. Because some of you may have heard U equals U, which means that when you are diagnosed with HIV, when you are on medications and undetectable, you do not transmit the virus to others. So this was a key theme that has come out over the last decade of research in HIV medicine. And what that means, if you think about it for a second, is that if we can test our way out of the HIV epidemic, if we test everyone with HIV, get those who are diagnosed on medications and undetectable, then they won't transmit, and we can essentially end the HIV epidemic. To do that across the US, all physicians, all medical providers really have to take part into that and buy into it. So again, regardless of what you go into, just keep in mind that $1 HIV test, it's all automated on their, trains through the lab there, is that we can test and end our way out of the HIV epidemic. I also want to make a case, HIV, we're doing fairly good work across the country, I think. It's the opposite for a lot of other STIs. So in the US over the last decade, we have seen really significant increases in syphilis, in gonorrhea, chlamydia, and other STIs. We're now seeing a resurgence in congenital syphilis, especially in other major urban settings throughout the US. So testing for other STIs is becoming and always has been of paramount importance. If we look at what the current CDC recommendations are recommending, you can see here, as I mentioned, HIV for everyone, Hep C, which is a relatively newer recommendation. Everyone should be diagnosed or should be tested for Hep C at least once in their lifetime. And again, we're also seeing a huge opioid and other substance use epidemic across America. So we are also seeing increasing numbers of Hep C. For cisgender women, as some of you may remember, that gonorrhea and chlamydia, especially, we see a lot of significant complications, especially in younger people who have vaginas. It can cause pelvic inflammatory disease, ectopic pregnancy, et cetera, et cetera. All these questions will be ending up on your boards at some point. So there's a pretty strong recommendation to test gonorrhea and chlamydia, especially in younger cisgender women, to prevent some of these complications. Because we are seeing the majority of HIV and a number of these other STIs in gay, bisexual, other men who have sex with men, there's a pretty strong and frequent recommendation for that group, meaning that we should be testing sexually active gay and bisexual men every 3 to 6 months. And what's also important is extragenital STI testing. Are people even aware of extragenital STI testing, swabbing of the throat, rectum? Some nodding heads, some shaking heads. So we have learned over time that when you check for gonorrhea chlamydia, right, what's the traditional way to do that? Pee in a cup. We have learned that if you're performing oral sex, or if you're bottoming, having receptive anal sex, that you can get gonorrhea chlamydia of the throat or the rectum that's not going to show up when you pee in that cup, right? And so for some populations, like gay and bisexual men, it's really critical to test these other sites. And what we do in our clinics, and this is recommended by the CDC, it's been validated through a lot of scientific research, is that we have people self-swab themselves. So it's more comfortable for the patient, more comfortable a lot of times for the clinician. Patients will swab their own throat. They will swab their own rectum. You're essentially using one of those Q-tip cotton swabs that goes in a couple centimeters into the rectum and then send it off to the lab. And the reason why it's more important, especially for gay and bisexual men, is because when you have any STI, it exponentially increases your risk for HIV by 3 to 5-fold. And so especially for rectal STIs, where you have more sensitive mucosa, where you have more sensitive portals of entry for HIV, that's how we're seeing, that's one of the reasons why we're seeing increased rates of HIV in that population. It's not because they're having more sexual partners, et cetera. It's because there's some biological reasons related to anal sex why we're seeing it there. So it's really important to screen and take that history, right? Always goes back to that history. It's really important to take that history about having receptive anal sex or bottoming so that you can screen appropriately for HIV, and also talk to them about PrEP, which I'll mention in a second. In terms of other gender diverse populations, it's also important to understand what a person's anatomy is, and STI screening should be based on that, as well as extragenital testing. And that's also a big gap and area of research, is that there's not a lot of data on STIs and HIV in different gender diverse populations. So that's one thing that we as a community, we as a scientific community are still learning about, and there's lots of areas for research in that group. So let me talk a little bit about some of our work in Rhode Island. So is anyone from Rhode Island? Any Rhode Islanders? Woo! So, I've lived in Rhode Island now for 15 years. It's the smallest state in the country. You can drive across it in 45 minutes, right? So, I won't tell other Rhode Islanders this, but, there's like one main city in Rhode Island, which is Providence, right? 300,000 people. It's close to the beach. I do encourage any of you, if you want to ever come down. We got beautiful beaches, wonderful food. I think the food actually in Vermont is the best in general. I really do mean that. The farm to table stuff is fantastic. But Rhode Island has wonderful, diverse food as well. But one of the reasons why I went to Brown is because of the HIV training. So through Brown University, very strong HIV program, something for those of you to consider if you're interested in that. And we also have a very high prevalence of LGBTQ individuals in the country. And interestingly, as of a few years ago, we never had an LGBTQ specific clinic. We do also within Providence proper, very high proportion of different Hispanic Latinx folks. If you look at some of the high schools within Providence, 80% identify as Hispanic Latino. And one thing that happened very early in my career is I got really involved in community medicine. And this also has been a great, I've really enjoyed it. Would encourage all of you to get involved in the community. And this has led from things like, this is Mr. Gay Rhode Island. Next to me here, Richie DeFilippo, who's been a good friend and colleague. We actually promoted in 2013, we partnered and promoted PrEP across the state of Rhode Island. Do people know what PrEP is? PrEP to prevent HIV infection? Mostly nodding heads. We'll talk a little bit more about that in a second. But really, when you talk about public health diseases, when you talk about addressing things like HIV and also, anything, it can be diabetes, right? Or high blood pressure or obesity, et cetera. I really believe that community engagement is so important in getting the message out. And it's been such a blessing to be involved in the community in Rhode Island to getting involved from the medical perspective, but also from the community perspective. We've done some community-based HIV testing. We've been to a lot of the clubs and the bars and the gay bathhouses. We've done a lot of work with some of the local community-based organizations who organize and run AIDS Walk, et cetera. But it's been an important part, at least for HIV, in addressing the epidemic, in engaging stakeholders from across the state to be able to address some of these topics. And this led to me, I graduated fellowship in 2011. I successfully applied and got an NIH K Award, which is kind of a junior faculty 5-year K Award. My K Award was on the molecular epidemiology of HIV transmission networks. So at the beginning of my career, and when I was here at UVM, I actually did a bit of basic science research. And I wanted to go to medical school because I didn't really want to do any basic science research. Sorry, Dean Page. But I wanted to make a difference in the community and really get involved in the community. And I really do believe that we have a bottleneck in our system where we know a lot of the answers, right? We know, for example, how to end HIV. We also know how to address COVID. We know we got vaccines. We know, flu vaccines, polio vaccines. There's been a resurgence of polio in New York State. We have the solutions to so many of these health problems, but what is the bottleneck? The bottleneck is that we have difficulty implementing them across our broader community, across our broader states. So that has been one of my focuses in medicine, is to get involved and to try to translate some of what we know from the scientific side, from the academic side, into effective community-based and public health approaches. And one thing that I did during my K Award period, by the way, if you don't know what molecular epidemiology means, all that variant stuff with COVID, that's like what I did with HIV. There's always variants of all viruses, and building out that tree of life and looking at some of these networks. It was pretty academic. And really one of the landmark things, though, that for my career that was so important was that when you get one of these NIH K Awards, you have 75% protected time to learn and to train. What did I do with my 75% protected time? I went out into the community and did HIV testing, et cetera. One of my mentors at the time was Ken Mayer. Ken Mayer is now full-time at the Fenway Community Health. He's was a wonderful mentor, wonderful gentleman. We used to do all this community-based HIV testing. Ken then went full-time up to the Harvard system. And I got sat down by my institution. They're like, Dr. Chan, we don't feel comfortable with you going out into the community anymore and doing HIV testing. It's not covered by liability and insurance, and we're not sharing exactly what you do. And so I was like, well, that's a little bit discouraging. But I'm like, okay. So what did I do? I actually opened up an STI clinic at our HIV program in Providence. And so I had approached my then division director at the time, another mentor, Dr. Tim Flanagan, adult ID doctor. And I'm like, Tim, we're having to shut down our HIV testing in the community. I would love it if we could offer it in our clinic. And he's like, sure, take this room. You can, Friday afternoons, you can run an STI clinic. And you know what? We as a division will cover that cost of STI testing. Because at the time, we really wanted to do anonymous HIV testing. There's still a lot of stigma, right? And a lot of hesitation, especially among the LGBT community, specifically gay and bisexual men, for HIV testing. So my division director at the time supported me. He, importantly, financially supported this clinic, and we started testing for HIV and other STIs. And we did outreach to the places that we had been physically testing now to our STI clinic. And this is what happened. So we essentially opened in the first month of 2012. I just graduated fellowship. That first year, we saw a few hundred patients, but it quickly ballooned and increased, and has since become really one of the leading safety net clinics in the entire state. And it's kind of a funny story because, as I mentioned, the Department of Medicine, the division, where it's covering these costs. And I'm not sure if people are aware about how much medicine costs, but I just talked about 3-site, STI testing. How much do you think a single test of gonorrhea costs? So at our institution, for just testing for gonorrhea of the throat or the rectum or the urine is $109 list price. So multiply that times, what did I just say that we should be doing? 6. So multiply that by 6, and then that's not including HIV, syphilis, et cetera. So it's expensive. So one of my soapbox points I often make is we need to make this more accessible because cost is one of the biggest barriers to all this. In any case, the department had committed during that first year to writing off maybe a few $1,000s of testing. And what happened was no one really checked in on the finances of the clinic for a few years. And it turned out, right? And it turned out somewhere in 2015, 2016, our hospital system switched over to Epic. And all of a sudden there's this huge alarm that went off and all these red flags, and they were writing off probably hundreds of thousands of dollars for this STI clinic. So I got the talk, I got called into the office and they're like, Dr. Chan, you can't continue to be offering all this testing for free and for anonymous. And you know what? They were right to some degree. And that's one thing that has also shaped my career. It's easy for me to sit up here and say, you know what, we need to do STI testing for everyone all the time. And that is a true statement, but we also have to work both as a community, a physician community, as a public health community on figuring sustainable solutions to be able to do this. So otherwise, a lot of this is pipe dreams. And we have to realize that unfortunately, whether or not we like it, is a lot of medicine is run and dictated by finances and business. So we have to figure out how to make our models sustainable and how to make them work. The challenges, though, is that I think, as everyone here may know, is that cost and out-of-pocket cost is a huge, in fact, the #1 barrier for so many parts of medical care, including HIV, STI care. The two #1 things that we've always found that have been barriers to STI care are cost, and what's the other one? Confidentiality, right? People are worried that this is going to show up on their, their insurance statements, that their partners are going to find out, et cetera. So this is a unique field. And the thing that I'm always struck, though, about STIs and COVID and public health is that the reason why that these issues are so important, though, is because they affect others around us, especially. So when you think about things like high blood pressure, not good. We need to address high blood pressure, but you can't transmit hypertension to someone else. But you can potentially transmit other things like HIV, STIs, COVID, et cetera. And that's why these things are such an important public health priority. The other thing that we've learned is the importance of advertising on social media. Now, look, I'm 44. It was my generation that just began to learn for online dating, right? So in my group of friends during my generation, I had a couple friends that had met partners on various apps, but it wasn't a thing yet. I'm guessing that most of you have a friend, if not yourself, that has met maybe at least someone online. So now it's integrated. And I won't pretend to be an expert in this, but I think that you all could probably teach me somewhat about this. But what we've learned scientifically and from a public health aspect about this is that, yes, especially in the cisgender gay community, gay male community, a lot of folks are using these apps, which are sex positive, which do facilitate social connections in general, not just sex. And we have tried to be pro social media, pro app, but we also have to recognize that a lot of folks are meeting sex partners on some of these apps as well. And we've done some studies that has basically shown that first off, the large majority of folks presenting to our STI clinic are using some of these apps and online hookup sites. And the popular one in our community, again, has been Grindr. And in fact, we found that 100% of people that had gonorrhea had met a partner, reported meeting a partner on Grindr in the past. So this was work done, it was published in 2018, but it was done years prior to that. So very early on, we had recognized the importance of engaging folks over social media, over some of these apps in sexual health topics. And this also led to PrEP. So what is PrEP? PrEP is a pill a day that prevents HIV. So PrEP has been a pillar. Again, I talked about testing and treatment for HIV. PrEP is really that third pillar in terms of how we're going to end the HIV epidemic. And some of you may not ever have heard about PrEP. Some of you may have heard about it in passing. The majority of public health efforts in the United States, including in a number of our states, has really been focused on cisgender, gay and bisexual men, because that's the group that's been most at risk of HIV. And that's one of the reasons why it's important to be able to take that history and to collect that, to be able to offer people things that may lead to, important preventative care like HIV prevention. And so just as a brief update here, there are now 3 FDA-approved medications for HIV PrEP. The first that came out was this first one up here, tenofovir disoproxil fumarate, emtricitabine. The brand name of that was Truvada. It's approved in 2012. The second one came out a few years ago, in 2019, tenofovir alafenamide, which is an updated PrEP. And the biggest thing in the HIV prevention world has been this new injectable PrEP called cabotegravir, which was just approved in December of 2021. It still hasn't been implemented quite yet. Clinics are a little bit slow in taking it up. It's a shot that you want to get every 8 weeks, but it's something that will be coming down the line and be used much more frequently. I think importantly, HIV prevention PrEP is becoming a lot like oral contraception in general, where you have multiple methods, you have multiple formulations that will be able to be used for HIV prevention. So in the field of HIV prevention, this is very exciting. And again, this is in one of the other ways that we are going to end the HIV epidemic. And very early on, first off, PrEP is very effective, very effective. There's only case reports out there of people who have become infected while adherent to PrEP. So it works. It is really effective. And it is recommended that all by the CDC, again, as part of primary care, as part of general care, that all sexually active adults and adolescents should be informed about PrEP, even if you don't have any identifiable risk factors. And that's important too, right? Because people don't always report risk factors. When I asked that first question in the beginning about, are you uncomfortable talking about sex? Well, if the physician's uncomfortable, the patients are also uncomfortable. And a lot of patients are uncomfortable about talking about sex. And especially for communities of color, especially for some of the communities that are most at risk, right? African-American, Black, and Hispanic Latinx communities. There's a lot of folks, a lot of cisgender males within those groups that identify as heterosexual, but are having other male partners. Those are some of the groups that would benefit most, right, from things like PrEP, 1 in 2 lifetime risk for Black gay men here in the US, but they may not identify as gay or bisexual. And therefore, the CDC and us in public health are largely trying to make this push about destigmatizing things like PrEP, destigmatizing things like HIV testing. Telling your patients things like, hey, we are just going to test you for HIV today, not because of anything that you've told me, but just because, it's recommended by, the United States Preventative Task Force. And you can see that in that manner, you've destigmatized it. It's not anything that they're doing or they've told you. And that is how we're going to destigmatize it. I will also mention that we also see in the state of Rhode Island, but also across the entire country, depending where you are, we also see a handful of people who are diagnosed with HIV every year that have no identifiable risk factors. And so the most common patient that we see that in is at least in Rhode Island, where I am, older Hispanic women who've had like 1 lifetime sex partner. And so what's happened? Well, their male partner, right, has been having lots of partners on the side. And despite the fact that this patient in front of me, this person in front of me, has only had 1 lifetime partner, they tested positive for HIV. A lot of times it's through blood donation. A lot of times it's through that insurance, testing, health testing. And it always breaks my heart because it is preventable. But also, this person really didn't have any of the typical, risk factors that we think about for HIV. Again, speaks to the fact that we should be doing routine HIV testing at least once on all people. I'm going to skip over some of these other slides just to talk about some of the work that we've done on PrEP. So one thing I encourage all of you to think about too, it's been commonplace now for the last few years in HIV to think about some of these public health challenges as a cascade. And so this helps to break down the problem. And I'm going to use PrEP as an example, but you can think about this for whatever area of interest that you may want to look at. And this is how I've started to really approach public health challenges, whether it be HIV prevention or PrEP or otherwise. And you can see here that there's a lot of different steps if you think about getting someone on PrEP who may be at risk to prevent HIV. And so these frameworks, which are now commonplace in the field of HIV, are very helpful in breaking down really difficult public health challenges and looking to develop interventions which can address those gaps. And I'm not going to go through all this data. You can read the papers if you're really interested. But one of the biggest things that we've seen in PrEP, and one of the biggest barriers, is that people generally don't think that they're at risk of HIV. And similar to you all, when you're younger, you're invincible, right? You don't ever think that things are going to happen to you. And this has been one of the big challenges too in the field of HIV, is people who get HIV generally have not thought that they were at risk of HIV or that they were going to get HIV. And you know what? That makes sense. When I was younger, I never thought anything bad would happen to me either. And I was lucky for the most part. Nothing bad really happened to me at all. So, but we have to recognize why, right? So I'm privileged. I feel privileged. And I think we have to recognize that, right? I'm privileged. I'm standing before you as a doctor who's been successful in medicine. I have not faced a lot of the challenges that I feel like my patients have faced. And I think we have to recognize that as well. We all come from different backgrounds. We all have different biases, right? And we have to recognize those and be cognizant. And really, when I hire other staff and when I look at other trainees, one of the things that I reflect on that I think is most important as a physician is you have to know your limits, right? You have to know your biases. You don't want to be that physician that knows everything, because no one knows everything, right? You have to recognize what you don't know, and you have to learn to know when to ask for help or look it up or refer to a colleague. So you want to be careful about that. And I try to do that at least. And that leads into some of the work that we've done here. Again, I'm going to skip over some of this because I want to talk about a clinic that we opened. So in Rhode Island, after we opened the STI clinic, which was a success, there were a number of places where people could get STI testing specifically. So Planned Parenthood, emergency departments. We try not to send people to emergency departments for STI care, but emergency departments, urgent care, primary care providers. But one thing that I kept hearing from my patients all the time, every day, was doc, we don't have a great place to receive primary care. I don't feel comfortable where I'm getting my primary care. I can't get in to see a primary care doctor. I don't know what to do. And I was being asked day in and day out to provide primary care services. And just thinking about, whether or not this be sexual health or others, right? When you go to the doctor, when you go to the clinic, what do you want to do? You want to call now and you want to be seen in 15 minutes, right? And where do you want to park, right? Do you want to park halfway across campus? No, you want to park right on the street in front of it to go to. And these are all challenges that patients face daily. And you know what? The less, health literacy, the more, the lower socioeconomic status, it's going to be the more barriers to successfully accessing healthcare. And so these are some of the things that we've seen over the years. None of them should be a surprise. Limited hours, right? People have to work, right? You all have to work or go to school. You will have to work eventually. Insurance status, out-of-pocket costs. You are working. I just mean you'll get paid to work, right? You're working for free at this point. But location, parking, how many of you have tried to get in touch with your doctor's office or tried to actually get in touch with your doctor, right? It's like an act of God to get in touch with your doctor, right? From the doctor perspective, we need that actually. We need a little bit of boundary and separation from our patients to maintain our sanity. So I don't have 1,000 patients texting me on any given day to tell me about all their health problems. But we need to find that balance between having our services accessible, having them available, et cetera. And when you start talking about LGBTQ care specifically, there's another whole set of barriers that come in that make it really difficult to engage. And this includes things like discrimination, stigma. A lot of my patients have reported fear and have been mistreated from engaging healthcare from prior experiences. It makes them reluctant to engage care at that time. And just the lack of services. It's like, my primary care doctor has no idea what PrEP is. Well, how do you think that makes you feel if the patient knows more about PrEP than the doctor that they're asking to prescribe it, right? That's not necessarily a great feeling. And then things, of course, like gender affirming care, and just in general, creating a welcoming environment, right? So not having the doctor office look like a dungeon, right? Or like a, 1960s. Well, you'd be surprised, right? How many community clinics, especially in some of the urban centers, don't look welcoming. We'll leave it at that. So I came across this framework a few years ago, and it really struck a chord in me. These are the 5 A's of what healthcare access should be. So you can see here, the first one is affordable. And this, again, I know I keep coming back to this, but we really, as physicians, have to learn to advocate for our patients who can't pay. We have to advocate to make our services affordable. And that could relate to HIV, STI care. It could relate to cardiology. It could be relate to pretty much anything. We have to make our services affordable or people won't use them. We also have to make them available. You know, the services that are most important to the community in terms of LGBTQ care, things like gender care. Is it accessible? You know, do you have to park across town? You know, where is the clinic? You know, where's the clinic located? You want to ideally have clinics located close to where people are so that it can be the most accessible. You want them to be accommodating, and you want it certainly to be accepting. And so one of the goals over time for my career has been to try to make services as accessible as possible and as patient-centered. And this led in 2020 to a vision that I had had for a while with a couple colleagues of starting a clinic from scratch. And let me just tell you that professionally, this has been one of the most challenging, but also one of the most fulfilling experiences that I've had. It's not every day that you start a clinic from scratch. And when I say start a clinic from scratch, we started it from scratch, from the EMR, from credentialing, from licensing. You know, we're official facility licensed through the state. We learned all of it, and things that you wouldn't even begin to think about, whether it be, sharps containers, vaccines, et cetera. It was a monumental task and one that I would not change for anything. The only thing that I would change is that we opened the day after our first COVID case was diagnosed in the state. Terrible timing. I will say, though, there obviously had been a couple of years of planning up until that point. We opened the clinic with a grant from the state. One thing that I've translated some of my research grant writing to is into programmatic grants. I think that that's one benefit of physicians. There's a lot of talk about NIH grants. By the way, I would totally encourage and recommend everyone to consider writing an NIHK award. It's the first, it's an important junior faculty grant, and it gives you protected time to pursue, open an STI clinic or do other academic things of interest to you. But the other thing about physicians and the power there is that you also have the ability to especially write and apply for programmatic grants, right? And this is an entire area that I was unfamiliar with, certainly at your stage, is that you can apply for grants that are focused and geared to things like opening a new clinic. And it's been wonderful. And the thing about grant writing is it frees up your time to do what you're passionate about. And so that's been why I've been able to do what I've been able to do, is because I've liked to write grants. Sounds a little weird maybe, but I've liked to write grants. And it's protected my time so that I'm not always in a clinic 5 days a week, taking call, et cetera. So it's protected my time to do some of these things that I feel passionate about. So anyway, there's my grant plug. I won't mention that again. But starting this clinic, amazing. We had to almost, in the first month or two of opening, we had to switch over to telemedicine because of the COVID pandemic. I think similar to Vermont, all reasonable states shut down with due to the pandemic. Sorry, I'm trying to stay away from politics, but I'm in public health. I'm a bleeding heart liberal. I also work for the public health department. So, we went to telemedicine. We tried to do the best we could with our patients. We made it a priority from the start about using correct pronouns. And just going back to my point, we struggled a little bit hiring front desk people, receptionists. We really made it a priority that all of our staff from the bottom up really had the mission and the value that we at the top did. And part of that was just making sure that all patients were treated equally, respectfully, affirming when they came in. So I want to give you a quick virtual tour of this clinic because, I'm a little bit proud of it. So the clinic was intentionally opened in one of the underserved areas of Providence. And, it was very interesting looking at real estate, right? This is not something that doctors do all day. But if you look at like the rich side of Providence, there's like 10 clinic buildings, right? There's like 10 buildings that we could instantly have rented. We went over to the underserved area of Providence and, there's nothing. So we actually had to build out a clinic from scratch. This is actually like a lawyer's office and an architect that we just combined and built it out. And the important thing is that it's right on street, so that the parking is right there on the street, and the front door of the clinic is right there. So people could essentially park on the street and walk 10 feet. It was right on a bus line. And I remember too, the first day that we looked at this site, there were people actually injecting drugs across the street. And I think for most people that would have been like, oh, like we're not even going to consider this place. But we all kind of like looked at each other and we're like, you know what, we think this spot is a good fit for what we want to do. And so we are currently focused on sexual health. But I think to my earlier slides, one thing that we do want to focus on, of course, is substance use treatment, mental health, maybe the biggest public health priority and unmet need, at least in our state and in many areas. But it's a great location. And, there's that statement, location, location, location. That includes medicine, right? And we need to not necessarily always open up clinics in the rich part of town, et cetera. I'm going to show a couple more slides about that. But you'll see that our waiting room was very affirming. We tried to give it an artsy look, et cetera. We got plants, right? Hopefully it doesn't look too much like a dungeon. We also built the clinic with data in mind, both to be able to tell the people who we serve, as well as to use for some of the grants which support the clinic. So we have a pretty robust data collection system that we report for the grants that we have. We currently have 3 exam rooms. We have a full-time NP, myself, and then a full-time physician's assistant, 2 RNs. But we just got a $2 million grant actually last year. So we're actually going to be expanding to 10 to 15 exam rooms and making a bunch of cluster hires. So if any of you want to come down to Providence in a few years, look me up, interested in LGBTQ care. Here's my shameless plug at the moment. We have cool bathrooms too. I can't take credit for those. They are not scratch and sniff. Sometimes people ask about that. But we have cool bathrooms. Again, a lot of this is for people who for the extra-genital testing, et cetera. One thing that's been cool about this clinic is that we've been able to pivot very rapidly to address emerging public health needs as well. So we were one of the first clinics to actually do COVID testing. We got some students, some volunteers, and we collaborated with our National Guard and opened up a COVID testing center right in the underserved area of Providence. We've also been ground zero for monkeypox. We diagnosed 1/3 of the monkeypox cases in the entire state, treated 1/3. This slide's a little bit older here. But we've been, our phones were ringing off the hook. We had to actually create a vaccine waiting list to address the need. And we are finally through getting vaccinating everyone through monkeypox. We've also tried to make a positive impact on the community. We actually partnered with the Avenue Concept, which is an art nonprofit, to do a mural on the outside of the building, just with the intent of adding a little art to the community. And also from earlier lessons, we've also launched aggressive and proactive social media campaigns, sex positive, very sex positive, the clinic, and launched a lot of different media campaigns to try to encourage people. And look, this is something too, right? So, back to my hospital system, some of these may not have passed muster with some of the top hospital leadership, right? So, but you know what? We run the clinic, so it's up to us. So that's been great to have that flexibility. So the clinic's been a big success. We have about 4,000 primary care patients as of this point. It's interesting, 2/3 to 3/4 do identify as part of the LGBTQ community. We also have a number of folks from the local community, a lot of folks who are uninsured, 16%, 5% of the entire state is uninsured. So we have a higher rate of those that are uninsured. And importantly as well, we also have a walk-in STI clinic, again, trying to decrease barriers to STI testing. We have a 28% STI positivity of everyone who walked through the door. So that is really a bit high. And even in the first year that we're open, we diagnosed 10% of all new HIV diagnoses in the state. So it had an immediate impact, which was, I had mixed feelings about this. Sure, it's great that we are doing this, but it's also speaks to the unmet need and the incredible disparities that we're seeing in that part of town. And finally, I just want to kind of go through, I'm going to go back to my concept of healthcare and clinic sustainability. Again, it's nice to say, like, shouldn't we have a clinic like this in every town and community, right? But how do you make something like this work? And so again, in looking at costs of running a clinic, and a lot of times these are hidden from the physician, and it's probably a good thing because there's a lot of them. But funding this clinic, making it sustainable has been a challenge. And one lesson learned for me with my healthcare administration hat on has been that clinical billing cannot sustain something like this. So we bill everyone that we can, everyone that has insurance. And again, the majority of our patients are insured, 85%. But despite that, we only cover a third of our operating expenses for our clinic. And that just, first off, I was surprised. Second off, it really speaks to the fact that, how do you deliver safety net funding to the people that need it most? And you know what? We haven't figured that out yet. So one of my challenges just to you all as you think about this is, first off, just make sure that your underserved patients, however you want to define that, do get the care that they deserve. We have a couple tiers of medical systems in this country, right? For people that are well insured, like many of us, but there's an entire subset of people in this country that do not get the care that they deserve. And we are still struggling to figure out how to provide care to them. And the fact that we have robust billing systems, we have a expert consultant who's guiding us through all this process. We cannot make this clinic sustainable based on clinical billing alone. We do have some safety net funding. Have people ever heard of 340B? Has anyone heard of 340B? One person, yay, way in the back there. So, 340B, I'm not going to go into it. You should read about it. It's an important safety net system that's under attack also in this country that funds clinics like ours, like other federally qualified health centers, but it also covers a third of our operating costs. And then because of our savviness with writing grants, which not all clinics can do, we offset the cost, again, a third of our clinic with writing grants as well. So we figured it out. We are figuring it out, but it has certainly been a challenge. And with that, I will just conclude with this slide. I think, again, we know that significant disparities exist. We know that LGBTQ individuals experience a disproportionate share of those barriers. I really have been a firm believer that sexual health needs to be integrated into primary care. How many people are going to go into primary care? Yeah, so a lot of you. So please make sure that you're good and talk about sex. I mean, look, I love my job. What do I get to talk about all day? I talk about sex all day, right? What's better than that? Sex, substance use, right? So I love my job. Also, I encourage us all as physicians and physician leaders to take that person-centered approach to improving healthcare access. Think about those folks who cannot always advocate for themselves. And especially for those of you who ever get involved in advocacy work, please do consider advocating for and looking at ways to make these systems sustainable. I do want to say it's been a team effort. I have a wonderful, wonderful, wonderful team behind me, and expanding every day. This slide is already outdated a couple of months ago, but really a great team behind us. And finally, I'm going to end on this slide. And this goes back to the very first point I made, which is none of us are really sure about where our career leads us. I talked about the main passion of my work, my main focus. But one thing also I did for the last year and a half was I was really involved in the COVID pandemic. I also serve as medical director of the Rhode Island Department of Health. In the bottom left here is our MD team, was our MD team at the Rhode Island Department of Health, all physicians there. I say was because 3 of those people have now left. Dr. Alexander Scott on the far right there went to take a national job. Dr. Jim McDonald is now medical director of the New York State Department of Health, and Dr. Klein in the middle there also left as well. So it's been challenging in public health. I did get my own podcast. Check us out. You'll see Bernie there, right? Speaking to the Vermont connection. But one thing too, I just want to make a plea to you all as you, in this stage of your career, is do consider getting involved. Getting involved in what? It doesn't matter, just get involved. I think one thing that we've seen is just the misinformation, the disinformation that has, permeated all aspects really now of life. And we really need more physicians just to think critically and just to be involved. And to that point, be involved in what? Do you have to run for president? No, but just school board, or just be a focus point in the community of people, of a trusted source of information and facts. And I've said this before, but I really believe that one of the greatest threats to our democracy is this degradation of facts and evidence. You don't know what to believe. You don't know who to believe. And very early in the pandemic in 2020, the governor at the time in Rhode Island did a bunch of focus groups. And you know who people believe? Gina Raimondo. But you know who people believe? People believe physicians. People believe physicians. And so very early on, top left corner here, they had me put on my white coat and get in front of the entire state and just talk about the importance of, masking and vaccination because people trust physicians. So I'm always reminded of that. It's a very powerful responsibility to have, I think. And again, I encourage you to get involved and to, speak and to be that trusted source in the community. And again, to my point about get involved about what, it really doesn't matter. Just get involved and be that voice, that trusted place in the community where people can come to you and listen to you. And, I'm humbled by the fact every day of my career. So with that, I'll end, but thank you very much for your attention.
Thank you so much, Dr. Chan, for an inspiring talk, and thank you for what you do in the community and for your bravery to step out and be courageous and do what you know the community needs.
Thank you very much.
We have some time now for questions. If you're asking questions in Zoom, you can use the chat function, and we'll get to as many as we possibly can. Emily and Krista have microphones. We've got one question in the audience right here.
Hi, I'm Clemens. I'm a second-year med student. Thank you for the really insightful talk. Recently this year in New York City, I believe one institution actually found they treated a woman living with HIV with cord blood, and it seemed like she was cured of it. They didn't detect any HIV in her body afterwards. So I'm curious, what's your opinion on this finding, and what are the implications moving forward regarding this possible cure of HIV?
Wonderful, great question. So the good news is that there's millions and millions of dollars that are going into HIV cure research. It's one of the hottest areas of research in HIV. The people that have been cured to date have been transplanted with bone marrow transplants, a mutation that has natural resistance to HIV. So it's called CCR5 deletion. That's a co-receptor that HIV uses to enter immune cells. And so if you have that deletion, you lose that co-receptor. And the people that have received some of these bone marrow transplants, cord blood, have been unable to become infected with HIV. Now, the issue is that to do that, you need to destroy the person's current immune system. So the people that it's been done to largely to date have been people with like leukemia and people that have needed bone marrow transplants. And so the mortality rate of that in general is around 25%. So it's not something that can be uniformly done across the population. However, it's been a proof of concept that people can be cured by HIV or have a functional cure. And so one of the things that I'm most optimistic about is actually HIV vaccines for people with HIV, with the thought that if you give a vaccine and can appropriately stimulate one's immune system to suppress HIV off medications, you'll essentially have a functional cure. So there's a lot of cool stuff going on in the HIV cure field. Good question.
We have a question from Zoom from Dr. Farrisee. Is it recommended to prescribe PrEP for patients who use IV drugs as part of harm reduction efforts?
Great question. It absolutely is. So there's good data now. There's a study done in 2012, 2013 that showed that PrEP is effective in injection drug use. And absolutely, I think one of the challenges sometimes in folks that do inject drugs is adherence, which is why I'm also excited about injectable PrEP. So one thing that that folks who work in the substance use field may want to consider implementing is cabotegravir for injectable PrEP. And then you can give this once every 2 months. And it could be something, for example, that you give while you're giving out methadone. And people don't have to remember to take that pill every day.
That's great. Thank you. Dr. Leonard.
So I actually trained when HIV was just being discovered in New York City. So it was an interesting time. Are we now at a point where we're diagnosing HIV early enough that we're not that it's not destroying the immune system of the individuals infected with it, so that there's, maintenance of the T cell counts and the T cell variability? I just don't know.
Yeah, great question. Great question. So just to make sure we're all on the same page, right? If someone were to be infected with HIV today, right? HIV is a disease of years. So people don't die. If you were to be infected today, you don't die tomorrow or next week. You see a slow degradation in most people of their immune system. 6 to 8 years later, their CD4 count drops to under 200. That means they're now they're at risk of getting opportunistic infections. That's the definition of being of having AIDS. And people generally live a year or two even after getting AIDS before they die, not from HIV necessarily, but from an opportunistic infection. And so that whole process in general, on average, takes 6 to 8 years. One can imagine with all the advances that we have is that people are being diagnosed very early, right? And we're not seeing people progress to AIDS. The unfortunate fact, though, is that we still see, depending where you look, and if you look across the US, that about a quarter of folks are still being diagnosed way over here when they have AIDS. And that means that they've had HIV for 5, 6+ years, et cetera. And a lot of times those are people that have been afraid to engage the medical system. A lot of times they have had prior medical engagements in EDs and urgent care centers, et cetera, which is why it's important to think about that as the front lines, et cetera. But we made some progress, but we definitely, there's still a subset of folks that are presenting late to care, et cetera.
We have a question up in the back.
Hi, Dr. Chan. My name is Jasmine. I'm a second-year medical student. I have a question about kind of the difficulty that you shared in terms of funding your center. And it was interesting because in the middle of kind of the different sections, you had philanthropy listed, but then you had not applicable. So I was wondering if that was maybe because philanthropy is not, like, in terms of reaching funding goals, it's not a reliable source of funds. Are you completely not using philanthropy? If you could just speak to that source of funding for a project
Great
like you've
question.
done.
Yep, thank you for that question. So philanthropy is an important part of what we do. But I think one thing to your point that I often worry about is, and for things like grants, these are what we consider soft money, right? If we did not get that, $1,000, $10, $10,000 donation like we did last year, how are we going to support the clinic? So I guess when I talk about sustainable sources of funding, we're really talking about hard money. What are some ways that we have, stable, sustainable revenue sources? So we definitely do some philanthropy. It definitely is an important source. And we use it as safety net, right? If we have a gap or we didn't quite get as much billing, revenue that we wanted at some point, then we kind of fill in that gap. So it is important. But again, I think we need to think about longer term sustainable solutions to fund some of these important healthcare services.
A question over here.
Hi, Dr. Chan. Thank you for being here with us today. My question is about how you navigate conversations with patients who are maybe new to the US or come from cultural backgrounds where talking about sex is, there's a lot of hesitation with it, especially for younger patients who maybe aren't used to talking about these things. Like, how do you balance good healthcare and having these discussions, but respecting different cultural perspectives about sex?
Yeah, so that's an excellent question. Thank you for that. So I'm reminded too, as a physician, that one of the things that we sometimes do that's most important for our patients is to listen. And so I usually start in understanding cultures that I'm not part of or less familiar with. Usually I listen and I ask a lot of questions and I try to gain a sense of who the person is, where their belief system is, et cetera. Sometimes it takes multiple conversations to get at what I really want to know it, right? You have to build that trust and relationship. If you think about what you're being asked to do sometimes, you're being asked to go into this room with this stranger and you have 15 minutes to basically ask about this person's deepest, darkest life secrets that they probably have not shared with anyone else in a lot of times, right? That's an almost impossible task, and yet occasionally we're successful at it. So I'm just reminded again to that point about trust, is I mean, it is a very sacred trust, and I think that we have to respect it. The other tip that sometimes I'll do is that I will normalize different things. So one thing, for example, that I may sometimes say is, you know, I find that a lot of my patients are meeting partners online. And some of my patients, you know, have reported, you know, 20 or 30 partners last month. You know, tell me about your, you know, what you do, right? And that way you're starting with normalizing that people are meeting partners online and people are having a lot of partners. I often get, the other thing too I try to do is I ask people to quantify, right? So if I say, you know, how often do you use condoms? Everyone always says most of the time, right? Now, what does most of the time mean, right? So most of the time ranges from never to, you know, never. But I ask people to quantify things because, you know, they'll give that initial answer. And a lot of times I'll say, well, what percentage of the time would you say? And then they'll be like 20% of the time, which is probably still an overestimate. So sometimes I do push people to quantify different things. Good question though. So trust and just multiple conversations. But those are some tricks.
A question down here.
And that can be quite expensive for some people, and the side effects can often be very uncomfortable. So I don't know if the same prep, but has become be an obstacle in getting that patient?
Yeah, so great question. So side effect about PrEP. The answer is yes and no. I mean, I'm reminded that the FDA approved PrEP for younger, otherwise healthy people. The safety profile of the PrEP medications is incredibly good. And at least for the Truvada medication, that's been approved for HIV treatment since 2007. So we have a lot of safety data on the medication, and it's really safe. What I do tell people a lot of times is when you first start it, you can have a little bit of stomach upset. Most people have nothing. Most people have nothing. But sometimes when people first start it, they have a little bit of stomach upset, maybe a headache. We generally tell people that's their body getting used to the medication. And then it usually goes away and people do fine. For a small subset of people, I think I've had 1% of people who've ever stopped the PrEP medication because of side effects. So again, very safe. But I do make the disclaimer, right, that any medication can have any side effect. And we even see this in over-the-counter, lots of over-the-counter meds, is that you can occasionally see very serious side effects from any medication. And so I just let people know, of course, patients know that if anything unusual happens, please do call me right away. I haven't seen anything really weird. I guess the weirdest thing I've seen with PrEP is rash, you know, a rash that wouldn't go away, you know, but I've never had a really significant life-threatening reaction in PrEP. So very safe medications.
We have a
Good
question from Zoom that I'll paraphrase, which is about 340B and how folks can get involved in making sure that this program is supported.
So 340B, this is how ridiculous our medical system is. So 340B is a program that's pushed by the federal government, by HHS. Essentially, it allows clinics that qualify to buy medications at the wholesale price, but to bill insurance at the full price. So what that means is that if you're getting your, you know, hypertensive med du jour, you're not really, as a clinic, as an organization, you're not earning a lot of money, right? You go to Walmart, you get the $4, you know, Lisinopril, you're maybe earning $1 per med. How much does PrEP cost for a month? List price, $1,600 per month. So first off, it's $1,600. It's largely inaccessible to a lot of people who may be uninsured. Now, there are safety net programs. So what happens is we as a clinic, because we have a 340B designation, we buy that medication for $800 and we charge the insurance company $1,600. So the clinic makes $800 on one patient for a 30-day prescription. Now you replicate that times 100 patients on PrEP and all of a sudden that's serious money. And so hospitals tend to qualify for this. The pharma companies don't like this because, well, you're giving money to clinics. But this is a critical safety net funding source for a lot of FQHCs and community clinics. So what's the best way to advocate for it? I mean, just being aware of the issue. I mean, I just in 3 sentences explained it, but it's incredibly complex. There's people that focus their careers on understanding 340B. So one thing that I often think about is why do we need a person who, with expertise in 340B? Why is it so overly complicated? That's another story. But just being able to advocate and know about 340B, because one person raised their hand about 340B. The fact that it funds 1/3 of our clinic, right, and no one knows about it, that's a problem. So if no one knows about it, then it can potentially be, pushed under the carpet, et cetera. So just educating yourself about some of the funding sources and being to advocate for things like that. That's a good question. Hopefully I answered your question.
I think you did. I think we have time for one more question up in the back.
Hi, my name is Hunter. I'm a M2. You use the term men who have sex with men a lot, and I noticed in your data you were pulling from like the LGBTQ community. And I was wondering how you were defining men who have sex with men and whether trans people were incorporated into that and how that works for you. And then also on the data collection side, a place where trans people are very often left out, how you navigate bettering data collection to improve HIV prevention and protection for trans people?
That is a great question. So 10 years ago, I guess I'll answer it. When you apply for a research grant, there's all these considerations like, power and all the sample size and all that stuff. And so historically what's happened is a lot of transgender and other non-binary folks have been excluded from research because the sample size numbers are too small to ever make firm conclusions. And so for a lot of our data, our earlier data and projects, we had gotten a lot of comments back, for example, from the NIH to only include cisgender men who have sex with men. My thinking in the last 5 years has really radically changed on that. And now I always make the argument to include transgender and non-binary communities in our research, despite the fact that we can rarely, if ever, draw firm conclusions based on the sample sizes that we have in our studies. And the reason for that goes back to something that I mentioned, which is if we don't even begin to describe the data, then we can't say anything about that group and about that population. And so I've completely changed and now tend to be inclusive, even when the sample sizes are small, at least to make some preliminary, at least to open the discussion and do some preliminary descriptives on people that otherwise aren't included. So that's one thing that I think a lot of my colleagues in the field of HIV, we're starting to shift to that, but just getting the data and understanding the extent of disparities and drawing attention to it, I think is an important part of collecting that data to show that these gaps do exist. So for us, because we have the data, we subset it out from cisgender, for cisgender MSM, and also for non-binary queer populations as well. So we do subset it out to look at it, depending on who we're reporting to. Sometimes we will include both of those together.
Thank you so much, Dr. Chan, for sharing your experience, your knowledge with us today. I also want to thank Dr. Imbasciani and George DiSalvo for sponsoring this lecture annually. It's really a cornerstone of our diversity, equity, and inclusion efforts at the college, and we're so proud of it. I also want to thank Dean Page and Dean Tando, who is not with us today, for their leadership and ongoing support in making our environment a safe, inclusive, and equitable environment. Thank you all for joining us, and have a safe and relaxing weekend with a little bit of studying splashed in.
Thank you.
Thank you.